Hi, everyone. My name is Madeline Souza, as Nick just said. Thank you, Nick. On behalf of Hermes Medical Solutions, I would like to thank the CANM for giving us the opportunity, this great opportunity to present today. Very much appreciated. So as you know, the pharmaceutical side of the nuclear medicine business is growing extremely fast and getting more and more important. This is the reason why we as a team at Hermes have thought it would make sense actually to have a presentation today on our dosimetry offerings. As everything else in nuclear medicine, Theranostics is a world of precision and accuracy. And Hermes is very committed in being part of the industry standards and also being a leader in the industry. So please let me introduce you to our physicist and dosimetry specialist, Andrew Prideaux.
Hello. I apologize. I was still messing with my audio when the introduction was given. I heard my name only. There you go.
Hello, my name's Andrew Prideaux, and I will be showing you the products that Hermes has in our dosimetry offerings. Before I begin, just a quick thing. I want to lay out a few terms. They're fairly standard, but just to be sure that we're using them in the same way, I will define resolution, and I both have a measurement resolution and a dose resolution, though in truth I don't think we vary those too often. But this is at what level we're measuring activity distribution in our patients. So voxel level, cellular level, organ or whole body, what measurements are we taking for how much activity is in what region. The dose resolution then usually follows the same, doesn't always have to. At what level is the dose going to be reported? Are we going to average? Are we going to have a mean organ dose? Are we going to have a dose per voxel? Are we going to have a whole body dose? And then likewise, we'll go into talking about kinetics, which is in this case how the time-dependent behavior of the activity is characterized. How do we know how many total disintegrations of our radioisotope are going to happen in that place? What's our time dependence? And then lastly, transport. And this is, okay, we're going to take the others, we're going to figure out how much energy is emitted. Where does that energy land, right? So we know where it's at when it starts, we know how much of it, and we know from what isotope it is how much energy, but how far does it go and get to where in our patient? So resolution, kinetics, and transport, and that'll help me define our products by how they do these. The first one is Olinda 2.0, which we've taken over the distribution of since Olinda 1.1. We've put out 2.0 as a fix for the fact that the 1.1 was not compliant with the average organ masses recommended by ICRP 89. And Michael Staben has done all of this work. We just redistributed, but the model was revisited. It was updated to reflect these new masses. New S factors were created, and it now can tally these, as well as some updates to the radioisotopes. So the resolution for this is, as already kind of alluded to, organ level. We're going to get mean organ level for what we measure. It's also going to be what we turn out for a dose distribution. The user supplies the normalized cumulative activity. We do, of course, offer some curve fitting, which will do this for you, but largely it is up to you to make your measurements and come up with how much activity as a percent of injected is in different time points and integrate that out. Transmission constants derived from phantom are of course used to calculate the dose. That's the transport. A Monte Carlo program is run for different energies, and as one source organ's contribution to others are tallied, and then that allows a large table of these. For this much in the organ X, contribute this much to organ Y, Z, and so on, and we can tally all of those. The nice thing about this is, as it was developed for not just patient treatment, but also exposure to radioactive isotopes, there's thousands of available isotopes, some of which are ones you would never want in your patient, but certainly all the ones that are clinically cleared are represented. And if you have any questions about them, it is quite a long list, but I'd be happy to verify ones that you might ask about. That takes us to our next one, organ dosimetry, which is related in the fact that what this is a front end for Olinda, an additional front end for Olinda. It lets you take patient imaging and calculate all of the values that normally would be on you to do in Excel from an image, guided with assistance. So in this, a lot of these things are the same in how we talk about it. The target and sources are organ level mean values, so our resolution is organ level. Image segmentation and curve fit are used to derive cumulative activity. So the kinetics, instead of you provide, like we saw in Olinda, this guides you through that as a form of image segmentation and curve fitting. Transmission constants derived from phantom used to calculate dose for the transport, because of course we're just going to feed this into Olinda, so of course we have that same mechanism and the same list of isotopes are available. A little bit more about the organ base before I moved on. It's based on Olinda 2.2 as indicated. The input for this can be any of these time linear images, so one injection, multiple images after. We can have 3 or more whole body planar images, 3 or more whole body planar images with the addition of a SPECT or a CT, 3 or more quantitative SPECT CTs, 1 SPECT CT or 1 whole body planar, and some unitless probe measurement for whole body clearance rate, like a Geiger-Muller tube from 6 foot away. And then also we could take 1 SPECT CT or whole body planar and assume physical decay after that, if that's all that's available. Hand-drawn regions with interpolation between drawn slices are used. So you hand draw a slice, and then you move several slices down, skipping a few, and draw another one, and the program will do its best to try and interpolate between those so that you don't have to go back. If it doesn't do a good job, you can edit places that you feel like it messed up, and so it's a nice way to save you a little bit of time in a hand-drawn method. Mean values of normalized counts in each organ are curve fit to give normalized cumulative activity. We kind of talked about that already. And then for each source organ, that's sent to Olinda. The one limitation of this model is that because everything comes from a phantom, it's not patient specific, though you can change the mass, and this program will help you do that to reflect the size of your individual patient's liver, kidney, spleen, and so on down the line, which makes the dose a lot more patient specific. But if your tumor is sitting in the middle of your liver, as an example, we see that a lot, of course, in neuroendocrine tumor, you're not going to have that reflected in your dose. We know it for a fact that if that is the setup, the tumor is going to contribute some dose that's going to bleed out of that tumor into the normal liver tissue. And to a much smaller degree, the normal liver tissue is going to give some dose back to that tumor, but that will not be accounted for, as the phantom that all of this was based on had no tumors, and if they did, it would never be in the right place anyway. So tumor dose is always done in this model, as an independent sphere, and it's done with self-dose only. And it's due to that and a few other limitations that we brought aboard our Voxel dosimetry, and this is the third product to speak of here. So in this one, the biggest difference here is the resolution. So the target and source are now at the voxel level rather than at the organ level. We do voxel to voxel alignment for all of the time points, and we curve fit to derive a cumulative activity per voxel. That's our kinetics. And the other thing that is different is, rather than rely on some pre-calculated factors, we are actually using your patient's CT as a density map, and your patient's cumulative activity derived from their specs or PETs to give us our cumulative activity, and we do transport via Monte Carlo, so random scattering model to figure out where that energy is distributed in your patient's specific anatomy. This currently supports gallium-68, indium-111, iodine-123 and 131, lutetium-177, tech-99, and Y90 as of right now for released versions. Future versions already being tested include a couple of versions of lead and holmium, and if you have a PET isotope, we're working to expand that list even more. So please let us know. A little bit more on voxel base before we move on. It's based on Monte Carlo, as already indicated, and the input for this is 3 or more quantitative SPECT CTs or PET CTs. Registration of each time point to user-selected anchor time point. So when you load in all of these images, the first thing you'll be asked is, which one of these do you want to use as your reference frame? And the most important here is that if you have a high resolution CT, as an example, you might pick the one with the best CT if the others are using lower dose CTs. Otherwise, it's arbitrary which one you move to. But you're going to register all those to that anchor time point, and then you're going to segment out the CT or the SPECT and PET, depending on which one you can best define the outline of the right liver, kidney, spleen, or tumor, whatever it is. But that segmentation is done again by hand drawn with an interpolation between. Segmentation is not needed in order for this to run, so you can run this program and then interpret the results later, as the output is just a voxel dose file. And tumor dose here is properly reflected because now we're actually using your patient's anatomy with the tumor and its uptake being properly represented directly from the imaging and not from some phantom or approximation. So this takes us through our more generic, useful for anything type dosimetry product. We have one foraging foray into, I suppose, a more targeted style. And so our cert here has 2 phases to it, I suppose. The first is planning, and this follows pharmaceutical on-label calculations. We can do the partition model, planning tumor volume, body surface area, or volumetric designations in order to generate what the injected activity should be from measurements of MMA to begin with. And this will help you order and treat with the right dose. You can also use the lung shunt. Or you can and have to calculate the lung shunt, I should say, in order to follow any of these pharmaceutical on-label calculations. The program will take you through that. And then through manual segmentation with interpolation again, you can define the regions needed for each of those models, usually liver, tumor, and section of liver that we're dealing with, or lobe of liver that we're dealing with. So all of this is a guided process helping you make the right decision in the next step, and eventually get you to a piece that you're seeing here where you can actually figure out, okay, what is the projected amount I should be injecting by those 3 methods. But what does make us different, because I think there's a lot of planning ones out there right now, is the verification. And here what we do is we predict the dose from an MMA distribution if we converted that to Y90 instead of Tec99 per voxel of uptake, and assume physical decay and look at what the dose distribution would be from there. We also, in parallel, calculate the dose from the actual Y90 distribution per voxel coming from the PET or Bremström SPECT reconstruction. You can know where that was actually distributed, and we can calculate what the dose would be from that distribution as opposed to the MMA. All of this, every product that I've shown so far though, really comes down to being well supported by one thing. Quantitative SPECT reconstruction, a last product that we do that is not directly dosimetry, but certainly feeds into all of them. So in here, what we have is a camera agnostic, camera vendor agnostic. We cover almost all of the DICOM spec CT cameras in existence. We can, with 2 heads, I guess I need to make that caveat, calibrate every 6 months with the isotope that you plan on using, and then when you do reconstruction, you will get quantitative SPECT directly from it. Like I said, it's camera vendor agnostic, and we do this by having an on-the-fly Monte Carlo scattering, correction, and attenuation, so we don't have to characterize one camera completely. We can actually characterize, all the styles of this and then tailor it to your camera purely by calibration. So these products, again, Olinda 2.2, for which we are a distributor, hybrid organ level dosimetry, voxel level dosimetry, CERT are all of our dosimetry products. Quantitative SPECT reconstruction is a great way to make them a little better, as it's a lot easier to properly normalize our images when we know their exact quantification. So those are our offerings. We're around for questions. Thank you for your attention. Have a good day.
Thank you very much. And now we are moving into the Q&A part of the session. I will now leave Mr. Prideaux is there to join and answer questions. I will just leave a little bit of time so that people can ask their question. We already have a couple of questions for you, Mr. Prideaux.
All right. Can you hear me?
Yes, perfect.
Perfect.
All right, so let's go with the first question, and then Madeleine can redirect it actually. Answer question for Mr. Prideaux. As you probably know, the dosimetry assessment has been mandatory in the EU for a year now. In the inspection of Theranostics, do you foresee this becoming a standard as well in Canada for the near future?
I do believe it's. Oh, I'm sorry. I got told my name, so I hope it was okay that I went directly for that. I do see it as being something that will be caught up to, or trickle down as something mandatory. I will say the importance of it will largely depend on what kind of determinations they're seeing in the EU to how is it impacting clinical behavior. But every indication so far from what we've seen from early adopters, from EU adopters who may not have had much of a choice, is that once actually implemented and taking that big step of getting started, it becomes quite easy to implement and therefore not a hindrance. And then we'll just see if it becomes a clinical benefit more. I'll also add one more thing, sorry. The other part of that is that we see also on the other side of the equation, a lot of pharmaceuticals now that previously could not come to market because they would have required very careful administration in order to see that they are given beneficially to the patient are now seeing dosimetry as a way to determine whether it's worth it to give it to the patient before they do it on a per patient basis, or just being required to figure out how much to give. So I think that there's two sides of that. One of them is we could follow the EU model where it just becomes mandatory everything we do. It also may, even if that doesn't go forward, become necessary to do it for specific medications that bring treatments that we don't currently have to patients, and then it'll be not directly mandatory, but probably best practice.
Thank you very much. We do have another question. How do you foresee the responsibilities of widespread clinical dosimetry being distributed within a clinical department, i.e. who has a draw in the EOI?
Yeah. Again, I'll take this one, I suppose, since it's still directly dosimetry related. The answer, I believe, is that we'll see a breakdown similar to something we do now, very much like kidney. In nuclear medicine, the kidney analysis is often broken up into responsibilities, right? Somebody has to draw the shape of the kidneys, then it's reviewed by a physician, and then followed up by checking that the numerics and so on work. I think the predicted one will be that it'll be on the nuclear medicine text to draw the regions of interest or volumes of interest or whatever is decided on for that dosimetry with physician review, and potentially maybe even in places that have one, physicist review, just to make sure all the numbers are making sense. But I don't think it's going to be particularly different necessarily from something that we do now, like renal analysis.
Fantastic. Anyone wants to add something on this? All right, perfect. Let me check if we did receive any other question. If not, Madeleine, I will leave you to the final words of this session. And no more question. So Madeleine, you have the floor.
Well, thanks again for giving us this great opportunity. I think it's we could discuss more and more, but I think we had not a lot of time today. Thank you for the questions, very interesting questions again. And I would like to remind you that there is a handout section, as you said in the beginning, with some documents that we made available for you. But if you would like more information, please don't hesitate to reach out to one of us or me directly, and it will be a pleasure to give you whatever you need in terms of documentation for dosimetry or anything else. Thank you so much.